Well, colleagues, thanks so much for having me. What a wonderful day, beautiful setting, and this is about the coolest setup for something like this I think I've ever seen. So kudos to all of you for putting this together. I know you're building an incredibly innovative system, and I know it's a complex job, and your health plan and hospitals, all sorts of new leaders. I know my colleague George Bolin is a board member. George sent me a wonderful note 2 days ago saying he's sorry he couldn't stay to see me. We served together for 10 years on the board of Catholic Healthcare Partners in Cincinnati, so you and I actually have a couple of pretty nice connections. Well, you've already had a busy morning, and I know you can't tell a bishop to hurry up to stay on schedule. So what we're going to do is the following. My job with you this morning, and we only have just a little less than an hour, so I'm going to try to do 4 things. So first, probably a little bit of review. How did we get in this jam? This video was pretty great. Care is variable. Care is of different quality. Care is expensive. You know this now as board members largely. So part 1 of our time together will be a little bit of review. How did we get in the jam we're in? And it's sort of depressing. And it's good that the doors are closed so no members of the laity can hear what we're going to talk about. Part 2, what's population health? Now, and how does it connect to quality? Since I have the privilege of being the dean of the only school of population health in the country, we've got the right answer. Part 3, can we connect population health to health reform and all the hard work that you're involved in? I think we can. I'm not going to get into the weeds of the act, certainly not, but I'm going to give you, so how do we drive population health through a patient-centered medical home, as an example? And then part 4, where are we going in the future? So quick review. Part 1, how do we get in this jam? Part 2, what the heck is population health? Part 3, how does it connect to health reform? And part 4, what does all this mean for the future? And then the good news is I get to get out of Dodge and you get to figure it out. So there you go. Okay, so let me get the technology to work. So first a little geography, and I want to make a special call out to my longtime colleague and one of your leaders, Dr. Peter Plantis. Peter and I met when we were both interns and residents in medicine in Philadelphia, so he knows where this is, but I thought we ought to do 1 minute of geography. So Thomas Jefferson University, colleagues, is not in Virginia. It is in downtown Philadelphia. This is the picture of our gymnasium floor where our undefeated basketball team plays, and that's because we don't got one. So Jefferson is a health sciences university, so all we do is healthcare. No pesky undergraduates, no business school, no law school, none of that. Medical school, nursing, pharmacy, allied health, graduate science, and the 6th smallest, newest, most agile, most innovative, the reason I'm here today, our School of Population Health. I've had the privilege of being on this campus as a faculty member for 25 years, the last 6 as the leader of our new school. More on that in a little bit. Okay, so I'm wearing a cool button that says Population Health, and in part, I'm here to help convince you that we're going to practice a new type of medicine, a new type of nursing care, a new type of pharmacy care, and it's all focused on the population, wherever our populations might be, and in your system's case, spread out now internationally, which is obviously very, very important. Some of the challenges that we're going to face, well, here's one. Whatever your politics, and I didn't make this up, so I want you to know this is not an internet doctored slide by my 23-year-old son. This is President Obama dressed up here. I'm not sure whether he's a surgeon, anesthesiologist, but colleagues, you can all agree that's a big syringe, and that's going to hurt. And we're going to come back to that when we talk about the future. Whatever your politics, please park it at the door for now. So we're still in part 1, the pain that we're suffering. So here's part of the pain, a little hard to read in the back of the room, but you could see the headline here in the Sunday New York Times almost a year ago, talking about subspecialist income in suburban Long Island, New York, just outside New York City, where I originally grew up. Here we have gastroenterologists and dermatologists netting seven-figure incomes in private practice, fee-for-service medicine. When we ask Joe and Jane on any main street in any major city in our country, hey, have your healthcare costs gone down since March of 2010? You know the answer that they give us. And in part, they read headlines like this in the Sunday New York Times of our clinical colleagues, at least in certain markets, making a very large amount of money. The other thing they read is stuff like this, and regrettably, Dr. Esther Nash and I are now regular readers of the AARP Bulletin. You get that joke, don't you? Yes? Okay. This is the most widely read magazine in the United States, 60 million subscribers. And maybe you missed this cover story recently, this past summer. Skip these tests, PSA screening, routine EKG. So this reminds me of a story this past summer. God bless my 91-year-old in-laws, both of whom are still alive and hanging on. So my 91-year-old father-in-law, Harry, goes to see his primary care doctor this past summer for his Medicare-sponsored annual wellness visit, and his knucklehead doctor orders a PSA test on my 91-year-old father-in-law. Now, colleagues, who paid for that PSA test? I'd like you all to raise your hands. This is audience participation. I don't see every hand up. Okay. So we'll come back to that theme too, as illustrated in that spectacular video. Overutilization, unnecessary testing. Certainly we could agree we are in an epidemic of that kind of behavior. So you could read along with me, all integrated national delivery systems like Christus are accountable to the public for their degree of success. And if you and I don't take on this responsibility, well, then the public will. Now, I could have written there October 2014, but colleagues, this is an exact citation from the inaugural meeting of the American College of Surgeons, no less, amazing, during the First World War at the Waldorf Astoria Hotel on Park Avenue in New York City, almost 100 years ago. So your whole meeting devoted to understanding public accountability, transparency, I would argue, colleagues, that we've been on this journey for a century, almost a century. The main message is, I think, that today we're 19% of the world's largest economic engine. It's largely unsustainable spending, and you as governance, you're in charge of sorting this out, not the president of the medical staff, quite frankly, not your chief medical officer, but the board has the ultimate responsibility for the mission here of public accountability and transparency. So I'd like you to think about transparency and accountability. We're going to come back to those two themes as well at the end of our time together. Well, how do you like this awesome picture? So here's an intern in medicine in those blue scrubs, and he's precariously balanced between these two canoes, and they're on this beautiful lake. And I stole this picture from the president of Bay Care in Tampa, Florida. Don't tell him, please. But on your left is a canoe with a backpack that says historical and current fee-for-service. And of course, on your right is the backpack that we're all hopefully headed towards, value-based payment, population health management. We're going to define all of this today. So here are the choices that we face, right? He could jump into the canoe on your left and think that everything is swell and make that seven-figure net income. What he doesn't know is downstream, about 2 football fields downstream, is a 1,000-foot waterfall, and he's going to perish. Now, he could jump in the drink and call it a day. And I have a lot of clinical colleagues in my age bracket now who say to me, David, one more tuition payment, one more mortgage payment, and I'm out of here. Or he could do what I hope Christus and Jefferson are struggling towards. I hope we're going to jump in that canoe labeled value-based payment, population health management, and lead our organizations to a successful future. That's really part of the struggle. So we have three choices. Like all biologic organisms, we can adapt, we can migrate, or we can perish. What choice are you going to make? And that's part of what we're all about. But let's stay in part one. We have some other difficult news to sort of internalize. Here's this wonderful teaching slide we use in our School of Population Health. Maybe you remember when Business Week was called Business Week and not Bloomberg Business. Anyway, here's the cover story, and get a load of this. So there's a doctor on a roulette wheel, and you could spin this hapless guy around. It lands on yoga, surgery, take 2 aspirin, call me in the morning. But read that headline, because it says, medical care from heart surgery to prostate care, we don't really know what we're doing. Now, everywhere but Christus and Jefferson, this is an issue. But the research behind this, 2 decades of health services research, some of it contributed to by some of the leaders in here, and your new chief medical officer, Tom Diller, who's a good friend. The health services research is irrefutable. 18% of what we do, plus or minus 2%, 20% of the time, we have solid, good evidence about exactly what it is we're about to do to you. The other 80% of the time, you and I call that the art of medicine. Now, if I make fun of the art of medicine, a bolt of lightning will come and strike me right here. But colleagues, 20% solid grade A randomized controlled trial evidence. The other 80%, largely we're winging it. Largely we're winging it. At the bedside, in the hospital, in the office, in the clinic, wherever we are. Now, we have the best of intentions, of course. Sometimes the evidentiary basis for what we do simply doesn't exist. You and I know that. But now that we're talking about 18, 19% of the GDP, now that we recognize that medical error is the 4th leading cause of death in our country, that's right. And colleagues, Tom Duncan died of a medical error, not necessarily from Ebola. So medical error is still an epidemic. More about that in a minute. So we've got some depressing news here. Transparency, public accountability, 19% of the GDP, 20% of the time we know what we're doing. I'm exhausted already. But there's more. For our international colleagues, wow. Maybe they read this report from January of 2013, a report that's almost 2 years old, got very little public attention. Read that subheadline, Shorter Lives, Poorer Health. So this report from the Institute of Medicine says, essentially, we're number 17 in the world, right behind Slovenia. Now, nothing disparaging about Slovenia, and I don't want to be on YouTube disparaging any country, but for real? Now, Americans are not rushing to get medical care in Slovenia. That's not the issue. But what 17 other countries have over us is a higher standard of living, a better quality of life, greater resilience, greater levels of happiness, lower mortality, and lower morbidity, despite the fact that we spend more than any other nation on the planet. Part one. Part two, the part that really gets me going, is that shorter lives, poorer health business. Your children and mine, for the first time since the Second World War, may have a shorter lifespan than you and me. We ought not to tolerate that. We're going to tie all this together in part 4, but this is pretty depressing. This is the state of our industry at the moment. Well, this is what the public sees. Of course, they don't read the IOM report. They read the Washington Post, and you get a headline like this, the least effective healthcare system out there, and the most expensive. Well, that's pretty dreadful. So Christus and Jefferson, we're working hard to fix this, but we can't do it on our own. We're going to need a whole national change agent movement to make this happen. So, leaders like Don Berwick and others, 16 years ago, writing in Annals of Internal Medicine, one of our core journals, detail's not important, but Don Berwick wrote, you know, we could improve outcomes and lower cost. When doctors first read this 16 years ago, they said, well, gee, what's Dr. Berwick smoking? Because we don't get that. How can you get a better outcome at a lower cost? Well, you know, as board members, we definitely can operationalize this, right? Let's start with, let's reduce medical error. That'll improve outcome and lower cost. Let's give the right drug to the right patient at the right time for the right indication at the right dose. The 5 rights, that'll reduce cost and improve outcome. Let's improve communication and not street a patient like Tom Duncan. Let's get our information technology backbone to really work. Let's give doctors and nurses and pharmacists good information about what the heck it is they're doing every day, teach them how to improve, and then get the heck out of their way so they can do a better job. Whoa, that's an exhausting agenda right there. So here's the IOM list of how to do it. Now, we're not going to go through all this morning, but note that prevent medical error is the #1 way to improve outcomes and lower cost. So in your conference about quality, that is the key take-home message. So we got a couple of messages already: transparency, accountability, number 17 in the world, 20% of what we do has good science, and we can improve outcomes and lower costs. Here's the battle plan where all your medical leaders across the system are working on, in your health plan and in your hospitals. Super important. We'll come back to that when we talk about reform. Okay, well, here's the best definition of quality that I know. This has been around since 1991, first promulgated by the IOM, so a pretty reputable source, but 1991, we've been at this a long time. So you could read along with me: the degree to which health services for individuals and population makes me feel good as the dean of the only school of population health. That's part 1. Part 2, desired health outcome. That means amazing. We got to ask patients what's important to them. Hallelujah. Do we do that today? Better question. Do we get paid to ask patients what their desired health outcome is? In our heart, every doctor in this room knows we do not get paid to do this. And the third thing, consistent with current professional knowledge, that's our code word for practice based on the best available evidence, when you can find it and where it exists. So summary: population focus, engage with the patient, more about that later, and evidence-based medicine. That's a tall order. So this is the best step for board members. This is it. This is the best definition I think I could find for you folks for sure. Okay, so everybody in this room by now, and I know we have one of the authors in the room, which is wonderful. So to err is human. You remember this book, right? 1999. Hard to imagine. President Bill Clinton was in the White House. You get that, right? And he held this up in the press room, and he said, "I commit my administration to reducing the epidemic," his words, "the epidemic of medical error." 15 years later, medical error, the 4th leading cause of death in our country. You don't believe me? Go read Peter Pronovost, Bob Wachter, Jim Bajan, and a host of the high priests of quality currently at work in our great country. What did this book do? Well, it enabled us to have this conversation. How do you like this cover story? That'll get your attention. This is Marty Macary's book from Johns Hopkins Medical School, my good friend, called Unaccountable Care. Now, that's a bestseller. Or as my wife would say, that's a page turner. How to stop hospitals from killing us. Yikes. By the way, board members, let me remind you, buck stops with you. It's all about you. The chair of your board quality committee and your board chair working together, they are ultimately responsible for this. Not the CEO, not the CMO, you guys. That's pretty scary. That's why you're here. So to err is human, 1999. The good news is, the last 20 years, we've been working hard at this. We've been trying to figure out, how do we fix this mess? And one of the most important things we've learned, of course, the top 10 ways to improve quality and safety, the #1 thing is, we all were taught by the time we were 5 years old, which is, of course, wash your hands. How ridiculous is this? So last week, I'm on the board of our own institution. 10 days ago or so, I attend a board meeting. We have 300 secret shoppers in our institution, medical students, nursing students, other people, watching to see whether we wash our hands. And the board was celebrating an 85% point prevalence hand washing day. What about those 15%? Would you want to be in that bed? Yikes. So we know what to do. This is leadership. This is all about education, leadership, facilitation, acting by example, leading by example.